Today we're doing a teaching video on the examination of the cardiac system. We have year 5 MD students. These are our final year students who will be doing their exams in August. And we also have some visiting students from abroad in the audience. Freddie, one of the students, has kindly volunteered to act as the guinea pig or to demonstrate the normal examination of the cardiac system. We're going to start as usual with the symptoms and follow it with so-called examination. The symptoms we will give an overview of, and I'll remind the students that the main symptoms in the cardiac system are relatively simple to remember because you can group them on their headings. The first grouping is the shortness of breath grouping, and that includes dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. The second big grouping is pain. Pain is very important for the cardiac system for a reason you will see later. Then we have the things that students may forget. You've got oedema, and then you have palpitations, and sometimes you have what we call syncope, or a loss of consciousness associated with low cardiac output. I think all students are aware that if your cardiac output stops, you lose consciousness immediately. Within a matter of seconds, you lose consciousness with no cardiac output. That's cardiac arrest. So therefore, syncope is a major symptom. Now, moving back to dyspnea. Dyspnea is probably the most sensitive index of cardiac function. And we start with dyspnea at rest and dyspnea on exertion. I'm reminding the students that it's most important to grade the dyspnea. And you may have to use something practical, like I am short of breath when I'm doing the activities of daily living, like dressing myself, feeding myself, or I'm short of breath when I walk a certain distance, and you can grade the distance, or I'm short of breath when I do more exercise than walking, like running or going upstairs. In other words, grade it, and that's important. All of these symptoms have what's called a time course. A time course means we need an onset, we need a duration, and we need how it is now. I emphasize those, and that's logical. Moving on to orthopnea. Orthopnea is just difficulty lying flat. And people themselves will tend to grade that in saying, I can only sleep sitting upright. And they can use pillows or support behind. And you have to ask the practical question. Can you lie flat at night when you go for sleep? And if not, how many pillows do you use? Paroxysmal nocturnal dyspnea, or what students know as air hunger, is familiar to you, and for some reason all students like it. Perhaps it's the terminology, and they all know what it means. It means waking up in the middle of the night from sleep, short of breath, requiring you to either sit at the edge of the bed or to go to an open window to get relief. And it's all to do with the reaccumulation of fluid from your periphery when you're lying flat. And of course the fluid is collected back into the cardiovascular system and stresses an already failing heart. Moving on to chest pain. Now, pain, what is particular about cardiac pain? Well, number one is position. It's central. If you remember, in respiratory system the pain is lateral. Now the origin of the pain is central, retrosternal usually, and it can be severe. And here we talk about the two main types of cardiac pain. Main types, there are other types. One is myocardial infarction, which is crushing retrosternal pressure, which may radiate. And where can it radiate to? It can radiate to the upper limbs, particularly the forearms, the inside, even the hands. It can go to the angle of the jaw or the neck. It can go to the back, interscapular area, and go to the epigastrium. So radiation is important. And we've mentioned severity, and we've mentioned type. associated factors are very important for cardiac pain because there's often a vasovagal response with sweating, vomiting, and pallor that characteristically occurs with it. The second type of cardiac pain is angina pectoris, or pain that is only brought on by exercise and relieved by rest, and that has to be brought out in the history. Now, associated with cardiac symptoms, you may or may not have a cough. And I think you recognize this particularly with pulmonary edema, where there's a cough which is productive of a white, frothy sputum. Now, we went through cough in the respiratory system, and I'm just emphasizing that the same criteria will apply in the cardiac system as you had in the respiratory system. You may have hemoptysis, characteristically left ventricular failure. You have what's called pulmonary edema with pink or frothy sputum, and that has to be brought out in the history. Moving on to the remaining three symptoms, the oedema, the palpitations, and the syncope. Palpitations is the subjective awareness of one's heartbeat, and that can be related to a normal heartbeat or to an irregular heartbeat. The trick there is to ask the patient about the time course when it comes on, and can the patient show you what they mean by the irregularity. And most patients are able to tap out the irregularity, like and that's a simple way of involving the patient in and getting more information from the patient. As regards oedema, it's self-explanatory, swelling of the legs. Please remember that when you go to bed at night, the oedema may get displaced to your sacrum. The patient won't tell you, I have oedema of my sacrum, because we don't look back there. That's where the doctor looks when he does the examination. And lastly, syncope. Well, syncope is loss of consciousness, and the classical cardiac condition that occurs in are low output states, aortic stenosis or cardiomyopathy, particularly hypertrophic, but it can occur in patients on antihypertensive medications, patients whose blood pressure drops suddenly, like pericardial effusion or low output state. So syncope is straightforward. Most patients actually don't lose consciousness. What happens is they get a subjective awareness of being very, very dizzy, and they are able to alter their position by sitting down, and stopping themselves goes unconscious. But please remember that syncope associated with either a heart block or with aortic stenosis is sudden. It's called Stokes-Adams attacks, and occurs usually without warning and can be very severe. So in summary then, we've mentioned to you the main symptomatology that one has to look for. Now moving on to the rest of the history, and I won't labor it today. Past medical history is going to be all about diseases affecting the cardiac system that you want to know about. Please remember, in all past histories you have to know, does the patient have any active disease? Have you ever been in hospital, and for what reason, and when? And have you ever had an operation, and for what reason? Specific cardiac diseases that you can inquire about is any previous heart disease, any hypertension, any diabetes. Was there maybe a history of rheumatic fever, which is usually not present, but there may be a history of rheumatic heart disease. So you emphasize that. Moving on to family history, we tend to concentrate on first-degree relatives, i.e. parents, what we call siblings or children, and our brothers and sisters, and ask again, do they have any of the risk factors for heart disease that might run in families? For example, hyperlipidemia, for example, diabetes, and hypertension. Social history is important in the sense of smoking and drinking are major risk factors, and now the latest one on the block is lifestyle, and that includes diet, and includes calorie intake, and includes exercise. So you have to accumulate those together. Obviously occupation is important depending on the type of exposure, just like it was in lung disease. The others, the drugs, here it's very important to document the drugs they're on, the dosage and the frequency, and are they still taking them. Allergies are obvious, and systems review you know about. So that concludes the symptomatology of the cardiovascular system. Thank you. So now we're going to proceed with the second part of the cardiac examination, which is the actual physical examination of the heart and the cardiovascular system. Please remember, the cardiovascular system is wider than just the heart. Involves the great vessels and the consequences of disease affecting them. To start with, your patient should be undressed to the waist and should be lying usually on a couch at 45-degree angle. That's where we examine the JVP from, and that's where we examine the precordium from, as a rule. Sometimes the patient is sitting in a chair because the patient is not in a bed. Today, our student Freddie is sitting upright for this examination. I'm just reminding you that just like the respiratory system, you inspect from the side and from the front. The front would be the end of the bed, or in this case, in this position, looking from the front. The examination then moves on to the, once your patient is positioned, then we move on to the examination of the cardiovascular system proper. And it involves the heart, but also peripheral parts that students may or may not forget. Now, no student forgets examining the pulse in the cardiovascular system, and that's considered to be part of the cardiovascular system proper, like blood pressure, like JVP. So they're included in the so-called, we call it the examination of the cardiovascular system proper. The bits that you may forget are the legs, where we're meant to check for oedema and for peripheral pulses. The hands, and by this now I mean the fingers, looking for clubbing, cyanosis, occasionally complicating bacterial endocarditis. We may see a little lesions, splinter hemorrhages, or little oscillous nodes, as they call them, little punctate little nodes that are embolic in nature, or Janeway lesions on the palms. So we are meant to carefully look for those things on the hands. Coming up to the head and the face, the things that students may forget is to look for anemia, because it will inform you about the cardiovascular system. Just like polycythemia may be a consequence of a cardiovascular disease, like cyanotic heart disease. And of course, in our environment, we see so many sick patients that the eyes may inform you from the point of view of jaundice, i.e. in congestive cardiac failure with hepatic congestion. The mouth is very important for two reasons. That is where we see peripheral and central cyanosis. And peripheral cyanosis is seen in the lips. In this case, he's not cyanosed, and then open your mouth, put your tongue out, and his tongue is normal. The tongue is where we look for central cyanosis. All students know that you only get cyanosis when you get greater than 5 grams of hemoglobin dissociated with dissociated hemoglobin, or hemoglobin that doesn't carry the normal amount of oxygen. Therefore, you can't get the sign if the patient is anemic. And we see a lot of anemia in our environment, concurrent with heart disease, so it's a sanitary point. Now, we've done the peripheral bits. The abdomen may also be involved in the cardiovascular system if the patient has hepatic congestion with a liver which is abnormal, or what we call enlarged. You may see ascites in severe congestive cardiac failure, and you may see a spleen complicating some acute disorders like bacterial endocarditis, or maybe some other diseases that may inform you about the cardiovascular system. I'm emphasizing that the peripheral parts do play a role, and I've emphasized the bits we're meant to examine. In summary, the feet, the hands, the head and face, and the abdomen. Now we go on to the examination of the cardiovascular system proper, and start with the pulse. There are 5 major things that we have to remember about the pulse. One is rhythm, rate, volume, character, arterial wall, and lastly, whether the other radial pulse is present. I'll re-emphasize those. The rate is self-explanatory. Anything above 100 is tachycardia, anything below 60 is a bradycardia. The rhythm is important, whether the pulse is regular or irregular. And students tend to like this because when we describe irregularity, it can be two types as well. We kind of reverse ourselves. Regularity can be regular or irregular. An example would be a 1 in 4 beat drop would be a regular irregularity, or a 1 in 2 beat drop, like in bispherials. And of course, irregularly irregular usually implies atrial fibrillation or multiple ectopics. So rhythm, volume informs you. And that's where we see two characteristic abnormalities. The volume reflects the stroke volume in the left ventricle and is best felt by gently pressing on the radial artery, gently, and feeling the volume that impinges onto your fingertips. The volume, as I say, can be normally decreased and sometimes increased, and or altered in terms of rhythm. For example, pulsus alternans, every second volume is decreased. That's a left ventricular failure. Pulsus paradoxus, the volume decreases on inspiration, such that it may disappear completely. And that can be confirmed by measuring the blood pressure at the same time. So I'm emphasizing that volume can be increased in high output states like pregnancy, anemia, tardive psychosis, and of course aortic incompetence, where you feel a full volume pulse. So we've done rate, we've done rhythm, we've done volume. Now the one that causes students problems, character. And I will summarize these two. Character is what makes a pulse distinguish from other pulses. The three main pulses that can be picked up at the wrist are as follows. Number one, an anacrotic or slow rising pulse that occurs in aortic stenosis. Number two, a collapsing or water hammer pulse or Corrigan's pulse that occurs in aortic incompetence. And the combination of both, bispherians, where you feel a slightly double impulse. There are other characteristic pulses, but I think that is sufficient for today. The feeling the vessel wall and the other radial is self-explanatory. I'm going to move on now up to the neck for the next part of the demonstration. The blood pressure is measured, and you're all aware of how to do that. Coming up to the neck. This is an area that students may find difficult because this is where we see an elevated jugular venous pressure. But the first thing a student will see will be a pulsation in the neck. The patient is lying at 45 degrees, there's an obvious pulsation in the neck. Your job is to decide whether this is arterial or venous. We have a method for distinguishing the two as follows. You start with inspection and you look at the pulse. Number one, you look at the actual, whether the pulse is localized to one area like an artery or spread over a wide area like a vein. Therefore, diffuse suggests vein, localized suggests artery. Number two, you look at waveform. A venous wave reflects the cardiac cycle in the right side of the heart and will contain an A wave and a V wave, which is easily visible. There's also a small C wave due to transmitted carotid pulsation. We call that the ACV, as opposed to an artery, which is a single, obviously, ventricular contraction, single waveform. And lastly, the venous wave will decrease on inspiration or vary on respiration, whereas an arterial wave is not affected by it. So on inspection, you can easily distinguish a vein from an artery. Now we move on to palpation. If you're still having difficulty, you can actually place your finger at the root of the neck and you can easily occlude a vein. You take your finger away. Please place your finger horizontally at the root of the neck, press gently, and you can easily occlude the vein, whereas you cannot occlude an artery. The artery is a midline, paramidline structure, and you would have to use a huge amount of pressure to occlude an artery. And of course, we don't do that. Lastly, you can do the hepatojugular reflux. If you press gently with your hand, and I emphasize you place your full hand over the epigastrium and the spanning, as much as you can, of the left lobe of the liver and the right lobe of the liver, and you press gently, and you'll see if the JVP is, if the pulsation is a vein, then that vein will distend and will become obvious. So I'm emphasizing that the difference between a vein and an artery can be distinguished clinically, and that is an exercise every medical student has to know. Moving on then to the cardiac examination system proper. The routine we follow is the same as for respiratory: inspection, palpation, percussion in brackets, and auscultation. Now what are we going to inspect? Well, you're interested in the apex beat, and you're interested in any abnormality that you see in the precordium. For example, if the chest wall is deformed. You're interested in any pulsations that you see around the precordium, or any other abnormality that strikes you. Please remember that you've already described the patient in your general assessment. The general appearance of the patient has already been described. Now you're looking specifically at the cardiac inspection. It's done from the front, and as I say, you localize the apex beat if you can see it, any abnormal pulsations or any other abnormality that strikes you. The important bits about palpation are as follows. Number one, we do palpate the trachea just to make sure it's in the midline, that the mediastinum is in the midline. The most important bits, I think, from the point of view of the student, are the apex beat, the precordium for pulsations, and then you need to check for the presence or absence of a thrill. Now the way we do that is as follows. Checking for the apex beat by palpation. The patient is lying at an angle of 45 degrees, and we usually just put your hand over the what we call the apex, or the mitral area, which is the 5th-inch space, midclavicular line, and you feel for any abnormal pulsation. And the problem is, what do we do when we feel it? Well, then you have to describe its location, how forceful or how weak it is, whether it is localized, like, or diffuse, and then is there any other associated character that you can feel, like a thrill or possibly a palpable sound, like a palpable first heart sound or a click. So I'm reminding you that the apex beat you describe its position, whether it's localized or diffuse, and then any other abnormality such as a thrill or possibly a palpable sound. Having completed the apex beat, I should say this: the apex beat is sometimes examined lying flat as well, with the patient lying recumbent or lying flat. The reason for that is you may get more information. Now, you've always been taught to examine the apex beat with the patient sitting upright at an angle of 45 degrees, and that still stands. Moving on then to what we call checking for precordial pulsations. You just put the flat of your hand on the left side of the sternum to feel any, and you may feel a pulsation onto the palm of your hand that way, particularly here where the right ventricle is. And then checking for thrills, you check over the base of the heart, over the left parasternal edge, and the flat of your hand now, not just your two fingers, over the whole apex of the heart. That way you feel for thrills. Palpation then is complete. The next part of the examination involves percussion. Now in practice we do not percuss hearts, but we can. So how could we percuss a heart, and when should we percuss a heart? Well, you might percuss a heart if you suspected that the heart size was very, very enlarged and you could pick it up clinically. The best example would be a large pericardial effusion. Cardiomegaly, yes, but probably less so than pericardial effusion. It's very simple to do. And most students are aware that there is an area of precardial, what we call dullness, that what we call underestimates the size of the heart. That is, it's small in the precordium, and that corresponds to the heart when you percuss. So let me demonstrate the way you would percuss. Well, let's imagine that Freddie's heart is here. He has the border here, the right border. He has an oblique border on the left side, which is at right angles to his shoulder, and he has an inferior border there, which lies on his diaphragm. All you do is percuss perpendicular to the borders as follows. Listen. You hear the dullness? And now going to the left shoulder, you percuss perpendicular to the You hear that? And then from below up, you can percuss as well in the same way. I can do it parallel or parallel with my finger or perpendicular. This is parallel because it's easier. If you listen, resonant. Now, in some respects, he will have a small area of dullness there that will underestimate the size of the heart. As I said, it's useful only when you suspect that there's massive cardiac enlargement and not routinely practiced. Now, I won't say any more about percussion. We move on then to auscultation. Now, as I said, auscultation is considered to be the most difficult part of examination for medical students for good reason, that it's not easy. The patient is lying at 45 degrees. You are going to listen at what we call 4 areas. And the areas are the mitral area, which is the apex beat, the aortic area, which is the second interspace to the right of the sternal edge, the pulmonary area, which is the second interspace to the left of the sternal edge, and the tricuspid area, which is the 5th interspace to the left of the sternal edge. These are the 4 areas. In practice, most people listen at 2 areas. Listen at the apex and the aortic area. But let's imagine that we're going to listen at his to his precordium, and we'll start at the mitral area. Okay, the apex. What am I going to listen for? Well, the first thing we listen for are heart sounds, S1 and S2. The loudest sound at the mitral area is always the first heart sound. So when I listen in there with my stethoscope and I hear a loud sound, I know that is the first heart sound. I'm going to use that to time my murmurs. On the other hand, if I listen in the aortic area, and the loudest sound in the aortic area will be the second heart sound. So I'm going to time my murmurs around that knowledge. Please, I am emphasizing that students must know heart sounds before they look for murmurs or any additional heart sounds. So let's look at Freddie's, let's listen to Freddie's heart for a minute and see what do I hear. Lub dub, dub dub, dub dub. Lub dub, loud first heart sound. Up here, lub dub, 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 dub. In other words, a loud second heart sound. I'm emphasizing the importance of heart sounds. That's the way we localize our murmurs. The other way we localize our murmurs is by palpation. Let's say he had a murmur and I could feel at his radial, but the gap between, the timing between his output and his radial is a fraction too long to use it to say that the murmur corresponds with it. So we're meant to feel his carotid artery, which is here, at the same time then as I'm listening to the murmur. Let's imagine he has a systolic murmur. Now the two are happening at the same time. So we time our murmurs by two methods. One is palpation and the other is localizing it around the first heart sound. I emphasize again that the cardiac cycle begins at the apex with the first heart sound, closure of the mitral and tricuspid, and it ends with the second heart sound, which is the closure of the aortic and the pulmonary. The first heart sound is always louder than the second heart sound. Therefore, any murmur that occurs after the first heart sound and before the second heart sound is systolic in timing. In the same way, if you listen up here, you'll hear two sounds, the second heart sound being the loudest, and in this case the first heart sound is the closure of the mitral and tricuspid, and the second heart sound is the aortic and pulmonary, but in this case the second heart sound is loudest, so any murmur occurring before the loudest sound is systolic in timing. Now, using that technique, we can actually localize our murmurs. Coming on to murmurs then. But before I do that, I should just dismiss additional heart sounds. There are at least 3 separate types of additional heart sounds that are common. One is a third of the fourth heart sound. 2 is what's called an opening snap that occurs in mitral stenosis. And 3 would be a pericardial friction rod. Going back to the additional heart sounds, a third heart sound is a diastolic sound that occurs during filling of the ventricle, passive filling of the ventricle, and is sometimes audible in young people, children, maybe in pregnancy or high output states. It can also be audible in a failing heart, usually and in that case it's considered, if it's coupled with a fast heart rate, we can often hear it as a gallop rhythm. A gallop rhythm would go something like this. It would go, and then if it was a gallop, that's a gallop rhythm, an extra sound. That's usually a third heart sound. As I said, a diastolic sound due to passive filling of the ventricle, which is already full of blood because it's not emptying properly. It creates a sound. In the same way, atrial contraction in diastole can create a sound that's called a fourth heart sound that occurs at the end of diastole, and that's always pathological. An opening snap is what happens after the second heart sound due to opening of the mitral valve, and it can create a sound if it's tethered or tight, a little snap. And that will occur before the murmur, and you may hear that in mitral stenosis. And finally, a pericardial friction rod. These are superficial sounds, and they're often systolic and diastolic in timing, heard best with the flat or the diaphragm part of the stethoscope, usually with the patient leaning forward and in expiration. And you may have to listen over the precordium at a number of sites. That's a pericardial friction rod. These are the additional heart sounds. Now, moving back to murmurs. There are at least 5 or 6 main points that students need to remember about a murmur. Number 1, where is it? Its site. Number 2, is it just confined to that site, or does it radiate in a certain direction? Number 3, its timing, whether it's systolic or diastolic, and I've explained to you how we do it. Number 4 would be what we call the quality of the murmur. There is some quality about that murmur which makes it distinctive. For example, mitral stenosis is a rumble, or what we call a low-pitched sound, a rumble, whereas mitral incompetence is a high-pitched blowing sound. And aortic stenosis would be what's called a harsh ejection type murmur, and aortic incompetence would be a decrescendo soft blowing type, soft murmur. So the character of the murmur is important. The loudness of the murmur is important, and there are 6 grades of loudness, beginning with 1 is audible by an expert, 2 by an ordinary person like you or me, and 3 would be an obvious murmur, 4 will be an obvious murmur with a trill, 5 is a murmur heard all over the precordium with a trill, and 6 you can hear it with your ordinary ears. I've emphasized the mitral stenosis in the left lateral position. Aortic incompetence, leaning forward, breathing out. And finally, which part of my stethoscope do I use for auscultation? In principle, we use the diaphragm, or the flat part of the stethoscope, for everything except mitral stenosis. That's an easy way of remembering it. Now, I've completed the examination of the cardiac system,